I am a geneticist and I am a pediatrician. I am not a pediatric geneticist and I do see adults. So if you're worried that I don't know what you have, I should be okay. Okay. So I was asked to give just an overview of Fabry disease, but a little bit of an emphasis on neurologic aspects of Fabry disease. So that's what we're going to go with today. These are my disclosures. As you can see, I will talk to almost anyone, anywhere, at any time about Fabry disease. There are other companies that I have been in discussions with, but have not actually done any projects with, and they would not be listed on here. Maybe in the future. So as you know, Fabry disease is a storage disease. It's caused by a deficiency in an enzyme that leads to buildup of a complex molecule that we'll call GL3 because it's unpronounceable. And that builds up in the cell, and it damages the cell in a couple of ways. One is it just changes the shape and the structure of the cell in ways that can interfere with their function. And the second way is the chemicals that build up irritate the cell, and so it sends out signals of distress, and that leads to inflammation and other changes. But the cell signaling is also very important in the cause of Fabry disease. So it's not as simple as if you make the cells look more normal, then then everything's going to be okay. We have to control both the cell signaling abnormalities and the distension of the cells. Now, that damage to the cells involves multiple body parts, and we will not talk about all of these, but essentially nearly every body system has some abnormalities in it. The ones listed up there are the ones that are most important, or at least most frequently noted by patients and by physicians and scientists. So we have abnormalities in skin, eyes, brain function, etc. And each of those are to some extent independent. You don't have the same degree of involvement of all of the organs in your body. And even within families, we will see times when somebody might have more kidney disease and a sibling might have more heart disease, and another person in the family might have strokes as sort of their biggest issue. And most people with Fabry disease have some abnormalities, if we look closely, in multiple body systems. So it gets complicated to know exactly what to do. Okay. So Fabry disease is divided in a couple of ways. One of the ways is on severity. The severe form, which is often referred to as classical Fabry disease, usually has less than 1% of the average predicted enzyme level. So essentially no enzyme. And that tends to present early in life. So there's various numbers published. If you survey adults and say, when did you first have symptoms of Fabry disease? They give numbers between 9 and 15 for age. If you ask families who have young children with Fabry disease when they first noted symptoms, you tend to get answers that are a little bit different between boys and girls, with boys being around 5 to 6 and girls more 8 to 9. And if you're Don Laney and you look very closely, prospectively at kids who are known from birth to have Fabry disease, you find that you can find evidence of symptoms of Fabry disease starting as early as 18 months. So there's a big discrepancy there. I think the younger estimates are more accurate because I know that as I get older, the specific timeline for my memories gets murkier. And so I suspect that that is true for the adults with Fabry disease as well. Partial deficiency of the enzyme. So between 5 and 30% of the predicted enzyme level still leads to disease, but it leads to a different pattern of disease, later onset, which isn't a surprise, but also just the pattern of involvement is different, with more specific focus on heart disease as the major risk factor, although not the only symptom, and then some variability in other manifestations. The onset for non-classical Fabry disease can be in adolescence, but it can also be in adulthood. And for some forms, it's common for it not to show up symptomatically until people are in their 50s. For example, the mutation that is most common in Taiwan rarely has manifestations or symptomatic manifestations before mid-40s to 50s or 60s. And that makes it a lot harder to know when to do something about that population. There are other modifiers for this. So the type of mutation that you have can be important. We're not going to talk a lot about that right now. And then if you have any other health problems. So if you have Fabry disease, that's not a guarantee that you don't have anything else. So if you have Fabry disease and lupus, Fabry disease and diabetes, Fabry disease and multiple sclerosis, or any number of other things, that's going to change your needs a little bit. And it changes, at least for some of those conditions, the progression rate and the involvement of the Fabry disease as well. So physical manifestations that we can see in Fabry disease are not very common. So we'll start with the eyeball up there. You can see some streaks of white going out in that slide, but you can't, if you look in the mirror, you won't see that. And even with an ophthalmoscope, I can't see that. You have to see that sign, you have to have a specialized piece of equipment called a slit lamp, and your average doctor doesn't have that. So unless you have very advanced eye disease, you don't usually see it. You can also see, if your doctors look at the back of your eyes, you can see changes in the blood vessels in the back of your eyes, again, only if you look carefully. And then the other two pictures are showing angiokeratomas. And I don't know how often you guys pay attention to what doctors are looking at, but generally speaking, belly buttons and palms of hands don't get looked at very closely. So it's easy to miss these things unless you have a lot of them. And the pictures up here, that's a kind of a typical amount of angiokeratoma involvement. There are people who have a lot more than that, and there are some people, even with classical Fabry disease, who don't have angiokeratomas. So this is from females, and I'm going to use a lot of examples from females today for two reasons. Thank you. One of them is that it was convenient. I've been asked to talk a lot about females lately, so I had this data pulled. And another one is a deliberate decision to sort of emphasize the females because, as we heard in the ice cream session yesterday, there are still a lot of people, a lot of females with Fabry disease who are getting their disease discounted or ignored, and that is wrong. So to try to shift the focus a little bit, not that anyone in this room necessarily needs that, but it was a deliberate decision to, if I'm drawing examples, not having data from both, that I would opt for female-centric. So this is the first symptom, and you will notice that there are a scattering of different first symptoms here: dermatologic, renal, gastro, cardio, ophthalmologic, cerebrovascular. But those are all in fairly small numbers. And then you have neuropathic pain jumping way up. And these numbers are even more skewed in men, although men tend to have more multi-system involvement early on. But pain is a significant focus that needs attention. Pain is seen in multiple categories of pain. When I first started, I was told that it causes burning pain in the hands and feet, and that is sort of the essence of it. And sometimes it's really severe and sometimes not so severe. When I talked to patients, they said, well, I have multiple kinds of pain. I have chronic pain that's every day, and it's annoying, but I can get through the day. Sometimes it gets worse at times, but most people have told me they can manage that, but it is a significant burden in their lives, and it distracts them, takes, and limits some activities. And then they have crisis pain, which is much more intense, is not there all the time, and can be completely incapacitating. And I wonder, is that actually different kinds of pain, or is it just that the severity gets much worse under certain circumstances? My patients, when I ask them about it, and I asked specifically that question, most of them said, no, it's different. It doesn't feel the same. And so that is something that isn't written about, but I trust you. And I think that it is different, and that emphasizes that we need more information on the kinds of pain. There are lots of things that can trigger the pain or aggravate the pain, particularly things like fevers, being very fatigued, increased physical activity, and other stresses or illnesses. So we want to pay attention to those. And that doesn't mean that you shouldn't do any physical activity, because you really should. And at least the patients in my practice that have decided that they were going to get into good physical condition, what they have reported most frequently is when they start to exercise, it increases their pain. But by the time they get into shape, and some of them getting into shape has been things like, I'm going to run a marathon, and I'm going, are you crazy? But when they did their pain decreased as they got into really good physical condition. I'm not saying that you should do that. You have to decide what you can do. And we have to sort of keep in mind that there's differences between individuals, but getting some physical activity is important for your general health. And that doesn't change because you have Fabry disease. It's a matter of doing it in a way that you can tolerate. But there are things that you can do. We need to keep that in mind. Now, that said, the pain is at times very severe, and we need to find good ways of treating that and good ways of measuring the pain. And unfortunately, we don't have those very much right now. There are some people who have an interest in that, but not a lot of them. So another thing that I think is important, this is a pediatric slide, it's mixed sex, but pediatric slide, pain is a common complaint in the general population. If you watch television at night, you see that from all of the advertisement that comes on. Pain is common in a lot of different health conditions and just in people who don't appear to have a specific health problem. But it's 5% in pediatric patients, and that's most commonly pain in the legs and feet. But that's more than 40% in the children with Fabry disease. And this was school-aged children. And I think that that skewing stays until adulthood, although really reliable numbers on that are hard to come by. Let's see. Okay, this is one on females. And again, you can see, so in the adult population, in the general population, 7 to 24% experience pain. But in the study that this data was pulled from, 77% of the adult females experienced pain. And of those, a substantial number reported frequent pain. And it's very commonly quite severe as well. So what do we do for the pain? So one of the things I think that is important is to know that while the pain is very important and can interfere with quality of life and with function, the pain in and of itself is usually not life-threatening. Now, it doesn't mean we should ignore it, not minimizing it, but I think it's important to do that. And the reason I mention that is there's a study done, this wasn't a Fabry disease study, but there was a study done a number of years ago in which they were trying to test some pain medicines and compare them with each other. And one person handed out the medication. So he met with everybody in the study and he would talk to them about their pain. And at the end of the study, they had 3 groups, an untreated group, drug 1, and drug 2. And they could not distinguish between the 3 groups, but the pain was real. And the people did have other health problems that would predict that there should be pain. And they were like, what happened? And instead of just tossing out the study and saying, well, that didn't work, somebody went back and analyzed it, and they saw that there was a steep drop-off in pain and the incapacity that came with the pain in all of the patients. They were like, what happened? And so they went to the patients and they said, talk to us about when you first started into this study. And what had happened is this guy had an idea in his mind about how to deal with pain and the thoughts about pain. And he had told these people a way of thinking about their pain that said, if you know your pain is real and you know it's not going to kill you and that it doesn't directly correlate with your overall health, then I want you to just put it in a box in a different space in your head and say, yes, I know you're there, but then not fear it and not focus on it. And he did that in a way that was so successful that that was better than the pain meds, and it washed out the effect of the meds that they had. Now, I don't know. I know that that technique has been studied since then, and it is consistently helpful. I don't know enough about it to be the counselor who tells you about that, but I want you to try to think about your pain in a way that acknowledges that it's real, it's not pretend, it's intense at times, but it also doesn't correlate with the degree of heart disease or your risk for stroke or your stage of kidney disease. It's an independent factor, and it does interfere to some extent, but it's not the thing that is going to shorten your life. in most cases. That said, we do have medications that have been looked at, and the neuroleptics are drugs that were invented as seizure medicines. Now, seizures are caused by your nerve cells firing when they're not supposed to. So if you do that, if you stabilize the cells in your peripheral nervous system that are firing when they shouldn't be, that cause the pain, that can decrease the amount of pain that you feel. That's why those drugs were thought about. That's why we think how they work. And there are other seizure medicines that could be put on there, but these are the ones that are most frequently used. Antidepressants also change and stabilize nerve cells, but they do it at the chemical level between the cells rather than the electronic transmission level. So they work in a different spot in the cycle, but they can still stabilize nerve cells the same way that they stabilize brain cells, and that can help with decreasing the pain. Since those two work in different places, it is fairly common to use both kinds of drugs at the same time if somebody needs that to get an additive effect. Now, the specific drugs that you would use, again, there are other antidepressants that could be considered. So the specific ones, that's between you and your clinician, but these are some of the ones that have been studied. Amitriptyline is another very common one that I didn't put on this slide. And then there are other things. So lidocaine is an anesthetic. We use it to inject if we need to numb up skin. And there are ointments with it, and that can help to some extent if you have pain that's focused like primarily in your feet, for example. And that one makes sense to me. I understand why we would do that because the drug numbs things up. Capsaicin is the oil that's in hot peppers that makes them burn. So why anybody ever thought that they would try that to treat their pain is beyond me. But what it does is it stimulates the nerve cells so that they are all at the same place. And that somehow leads them to not overreact as much. And that allows for them to help with the topical pain. Now, it doesn't work for everyone. But if you have pain that is incompletely controlled and that is in a place that you could cover with lotion or something, this is something worth thinking about because they've had patients who feel like it's very helpful. And it would work, I think, in a similar way to putting your hands or feet in like cold water by sort of causing massive stimulation at once and then having that somehow lead to stabilization. Cannabinoids are THC and related drugs, and those we don't know exactly how they work for pain. They have been reported to work for pain. They have not been studied well in Fabry disease, but the pain that is part of diabetes and part of MS is similar in distribution and in description to the pain associated with Fabry disease, and they have been found to be helpful in those. Again, talk to your specific physician about whether or not those are an option. Tramadol is an injectable, and it is good for trying to break a crisis when you have particularly severe pain, but you have to go to a doctor's office or an emergency department to get access to that one. And it's not a good maintenance medicine. Tylenol works for some people who have very mild pain. And there are others. We usually only use opioids and non-steroidal anti-inflammatories like ibuprofen. If there isn't any other option and the pain is very severe, the opioids, it's because of the addictive potential and because they are not particularly effective for this type of pain. And the NSAIDs because they are metabolized through the kidneys and you want to protect your kidneys when you have Fabry disease particularly. Okay, cerebrovascular disease, stroke is very common. This top layer or top couple of columns is from a brand new paper published in August of this year. And it's looked, one of the things included in the paper was stroke incidence. It is an older population of patients with Fabry disease, average age 48. And in the men, in this study, it was 135 patients. 52% of the men had had a stroke or a TIA or more than one, and 41% of the women. Those are very high risks. This is the best numbers that I have seen as far as getting people at a stage in life where we would have most reliable. The bottom two are from a different study, and they are looking at the age at which the first event happened. And obviously that's pretty young. Men in their 30s, women in their mid 40s. So we need to pay attention to that. This one is similar kinds of numbers, a different study. You will see that the numbers are not the same. I put this one in because it has the general population risk. So women over 18 years of age have a between 2 and 3% chance of having a stroke, with the average or the majority of those patients that have strokes were older than 75. Now, remember the numbers for the Fabry patients from the previous slide. That is a big difference. And then over on the other side, you see the numbers for a different study in people with Fabry disease. Now, stroke is something that is hard to predict. We don't have good algorithms. And even though a high percentage of people with Fabry disease have strokes, they don't have them at the same time. They don't have them at a predictable age. The oldest patient that I have seen who had a first stroke was in their 80s, I think. And that's a pretty typical age for the general population. And I wasn't sure that the Fabry disease had caused that. The youngest patient I have seen who had had a stroke, I didn't see her at age 9, but she had her stroke at age 9. And I didn't believe it. I thought that cannot be right because stroke isn't a pediatric thing. But I pulled it, and the imaging, it was unquestionably. I am aware of and have met 4 or 5 patients in adolescence or childhood who have had strokes. So this is something to be aware of in children. The next thing is, well, what do we do about that? So leading a healthy lifestyle, getting adequate exercise, eating a healthy diet helps with that. As you get older and your risk goes up, your doctors may talk to you about anticoagulants, and those also can help to reduce risk. Now, they are not recommended, anticoagulants are not recommended for adults in the general population because the risk of the anticoagulants is higher than their risk of stroke. And so you get complications that are felt to be more important numerically in the number of people that they would happen to than the number of strokes prevented. Okay, so I got too much on that. Fatigue is another important place. This one is not necessarily neurologic, but let's 70% of men and women with Fabry disease report significant abnormal fatigue. And in 48%, again, both sexes, that is at times incapacitating. We need to pay attention to that. That is just starting to get the attention that it deserves. There are things that can be done to help with that, but we do not have a lot of, we don't have any validated recommendations at this time. I use the same treatments that I would use for people without Fabry disease for that kind of symptomatology. GI is also common. 60 to 70% of people with Fabry disease will have some GI complaints. Now, GI complaints are common in the general population. About a quarter of the general population will have chronic abdominal pain or other GI complaints. Diarrhea, nausea, and vomiting, which are also very common in Fabry disease, are less common in the general population. Okay. It can move around. Often, especially the diarrhea, is right after meals. And that means you have to get to the bathroom quickly. You probably know more about that than I do. Worsens in periods of stress. You will find that's a theme in Fabry disease. Kidney disease, you're going to hear about from somebody else. But I think it's very important that there's a big difference between men and women for this one. For classical Fabry disease, essentially 100% of men have significant kidney disease. Not all of them will go into kidney failure, but untreated, most will. For women, they do have kidney disease if we do biopsies, but only probably 10% will go to end-stage kidney disease. That doesn't mean you can ignore your kidneys if you're a woman, or even if you're a woman who doesn't have symptoms related to your kidneys. It just means that it's going to be less of a focus. Heart disease is the major life-threatening issue for both men and women. So all of the people with Fabry disease need to pay attention to this. You'll hear more about that from somebody else too. So we will skip through these. Lymphedema is pooling of fluid in your lower legs. It can lead to pitting edema. When it gets severe, can become life-threatening. I have lost at least 2 patients to this complication. It happens in at least 15% of patients with Fabry disease, probably more than that. And it is a treatable issue. But you have to start the treatment early because, as with most things with Fabry disease, you can't reverse it. You can try to stabilize it where it is. And we'll skip that one as well. Treatment initiation in Fabry disease. In my mind, we're not doing it early enough. We should, once we know that somebody is going to have progressive disease or somebody has symptoms that we are confident are due to their Fabry disease, they should be started on treatment. There is not benefit to waiting, except to the insurance company, and they are making plenty of money anyway. These are symptoms of Fabry disease. And for each of these things, there are treatments that are not Fabry specific, and those treatments do help. So having treatment for your anxiety and depression, independent of the treatment for that's specifically focused on your Fabry disease, is a good idea. And each of these, proteinuria, renal failure, heart disease, GI symptoms, lymphedema, each of these have symptom-specific treatments, and those do work in Fabry disease. They've been looked at and should be a part of your considerations. So in conclusion, Fabry disease is an important issue. It's X-linked. It affects men and women. There are treatments for it that are specific to Fabry disease and change the physiology of the Fabry disease. And there are treatments that are specific to the symptoms that you have.